For this topic, I know we're using the kidneys as an example, but the concept will be the same. So regardless if we transplant a heart, a lung, kidney, a liver, eye, or whatever other tissue or organ we're going to transplant, the principle is the same. Okay, the concept is the same. Only the manifestations will be different. Make sense? Because are all organs have the same function? No, of course not. Okay, kidneys have a specific function, lungs, heart, liver. Your eyes have different functions. So therefore, the manifestations of kidney rejection will of course be different. Okay. So when we say kidney transplantation, what is the or any organ that's being transplanted here? What are we actually doing? We're taking somebody's organ or tissue, put it into somebody else. Now, how will this work? Since each person is unique, right? So each person has a unique fingerprint, has a unique DNA, has a unique HLA. What is HLA? Every cell in our body, whether it's a hair cell, skin cell, blood cell, kidney, heart, whatever organ cell, has a specific ID. That ID is called human leukocyte antigen. It allows your body to recognize self from non-self. Meaning, have you ever wondered how does your immune system recognize a foreign cell, a foreign organism versus your own body? How do they do that? Do they have eyes? And do they have a secret handshake that if a cell comes along, doesn't know the secret handshake, oh, you're an intruder. How does it work? How does our body identify self from others? The human leukocyte antigen. Okay, so immune system, of course, circulates throughout your body, and as they do so, they bump into other cells, correct? Because they enter every part of your body. As they do that, of course, they will come in contact with other cells. No problem, because once they come in contact, there are um, protein signatures on the surface of each cell, meaning that's what we call the human leukocyte antigen. Meaning, as they bump into one cell and another, they recognize each other. Oops, the same HLA. Okay, same. And then once they encounter a cell, that cell can be a cancer cell, that could be a virus, that could be a fungus, a bacterium, whatever cell that doesn't have the same HLA, what will your immune system do? Activate the immune response. Activate, hey, intruder alert. And then they will try to kill and destroy that identified foreign foreign body. Does that make sense? Okay. So since now I'm me and Miss Stephanie is Stephanie, so how do I know if if let's say I need a kidney, right? So the only since me and Stephanie don't have the same HLAs, can I just get her organ and then put it inside me? No, because I have to see if they match. Will there be ever be an exact match though? No, unless I have an identical twin. Fraternal twins never have a match because they're two separate eggs, right? However, identical twins, since they come from the same egg and they just split, so of course they have the same HLA. Now, how many of you here have identical twins? Oh, thank God, there's only one of you, right? So, so imagine if there's two of you. So we have two problems now, right? Okay, so anyway, so since most of us here don't have identical twins, so what will happen to us if we ever need a transplant someday? Say we lose our kidneys, our hearts fail, our lungs fail, right? We go blind. So now we require a transplant. Okay, so we'll be placed on the transplant list there's a huge there's a long line of recipients waiting for organs. So of course, the organ donors will either be a cadaver, someone who just died a few hours ago from an accident or got shot, for instance, okay, a few hours ago, right? Or let's say people who are dying in the hospital, right? Have you heard of Live On New York? Live On, no, Libeon, no, Live On. Okay, it's a donor organization. So they're actively looking for donors. They prefer, of course, living donors over cadavers. But they have an office in every hospital all over New York State. There's a Live On office, okay, in every facility, and they will, of course, um, keep in touch with the doctors, the nurses, okay, for possible organ donors, right? Especially those who are dying in the ICU. So they will ask for referral, and then they'll be the ones to contact the family, okay, and they'll do tests, they'll look at the patient's labs to see if it's an appropriate donor. Okay, of course, they have to identify is that patient an organ donor. If not, no problem, they will contact the family. Okay, they know what to do. So, so let's say they find a match. Okay, so they'll go through the process. They'll match the donor and the recipient. Okay, so we'll call the organ or tissue that we're going to transplant as the graft. Okay, so if it's a kidney or a bone marrow, for instance, we call that a graft, right? And then the person receiving that we will call the host. Okay, so graft and then host. Who's the graft again? The organ or the tissue. Who's the host? The recipient. Okay, so we will, of course, do cytology studies. First step is, of course, blood typing. It has to be the same blood type. Then once the blood type is matched, okay, then let's go with cytology. Okay, so we'll look at the HLA. Are they close enough? Once we find a close enough, remember, there's no exact match. It's impossible. We will only find a close enough match. And once we do, okay, we will contact the providers concerned and also the host and the donor. Okay. And then we'll arrange it. Right. Now, since it's never an exact match, what will your immune system do once we place that organ or tissue inside your body, inside the host body? What will the host immune system do? Of course, it will automatically attack it, right? Because you're not one of us. Okay, you don't have the same HLA. You're dead. Okay, we're gonna kill you. So what will prevent the host immune system from killing the graft in this scenario? We have to immunosuppress the host. Are we clear? All right. So before surgery, of course, we will have to, and we have the drugs here, right? We have the medications. It'll be the same medications, regardless if it's a heart organ, heart, liver, eye, kidney transplant, whatever we're transplanting, it'll be the same medications we're using. Okay. Now, the beauty about these medications is they are cell specific, meaning, yes, they will weaken your immune system, but not broadly. Okay, meaning they will only target specific immune system cells, particularly responsible for organ rejection. Because not all of your immune system cells are going to reject an organ. Okay, only specific cells in your immune system. Okay, we'll talk about those shortly. Okay, they are cell specific. However, regardless of our and this I won't test you about the because we're not concerned about this. We're not the ones participating in the testing for infectious disease. Okay, none of these, so we'll skip that. We are concerned on the because our job is to recognize the signs and symptoms of a rejection because we can't absolutely prevent a rejection. And of course, our job is to administer the medications and then, of course, provide patient teachings. Okay. So as already mentioned, we're going to immunosuppress the host, and depending on the donor, if the donor is a cadaver, then there's no need to immunosuppress. But if the donor is a living donor, then we will have to immunosuppress the living donor as well. Okay, so both the donor and the recipient will be immunocompromised, will be immunosuppressed. Okay. And in the case of the kidney, as described here, so they usually leave the diseased kidney alone. I mean, it's alive, but it's not functioning, obviously, right? So they'll just leave it alone. And then they'll put the transplanted kidney here in the pelvic area. And since the renal arteries and veins are huge, they usually don't want to use those because they'll have a bloodbath in the OR. So they'll use the smaller iliac arteries and veins, right? And then instead of the ureters, they'll use the donor ureters and put them straight into the bladder. Anyway, so that's nice to know. Let's go to the rejection. Okay? Because there's no exact HLA match, all we can do is good enough, correct? So all we need to do is immunosuppress the host immune system. That way it does not destroy the graft, right? So this will be forever. Now, have you heard of the saying that what doesn't kill you makes you stronger? All right. So the immune system of the host, will they some days finally say, oh, you know what? Let's say it's Stephanie's kidneys that she gave to me. Okay. So will my immune system someday, so this is 5 years, 10 years later, will my immune system say get tired and then just say, I give up? Okay. I can't kill you because no, my body's taking immunosuppressants, and I guess you're not harming me, you're actually helping. So let's just be friends. Okay. You will adopt you, okay? We're going to uh, adopt you. We'll have some papers, and then you're one of us now. Will that ever happen? No, because Stephanie's kidney is a different HLA. She'll forever be born, right? She will always be branded as she's gonna eat the cats and dogs in my body, right? You understand? Okay, so my immune system mission will always be to destroy Stephanie. Okay, so my immune system will say, one day, watch your back. Okay. There are three types of rejection. So after surgery, we will answer three questions on the exam with organ rejection. There are three types of rejection. Three questions will be, when will it happen? Number two is, how do I know? Why did it happen? And then number three, what can we do about it? Because the signs and symptoms, of course, again, is specific. So I guess there are four questions. But the questions on signs and symptoms will basically be, since it's destroying, when we say organ rejection, it's actually destroying the graft, right? So what is basically the result? If my body is destroying an organ, what manifestations will it have? Let's say it's kidney. I have a transplanted kidney and that kidney is being destroyed. So what will be the manifestations? Kidney failure, correct? Make sense? What if it's my liver that was transplanted and then my body is destroying that liver? What will be the manifestations? Liver failure. What if it's the heart that's being destroyed? Etc. Make sense? All right. So again, we'll just focus on the three questions, which are, when does that rejection happen? What exactly happened? And then third is, well, what can we do about it? All right. Okay. So let's start. There are three types of rejection. This is good for, again, any organ or graft. So it could be heart, liver, eyes, kidney, skin, whatever we're transplanting. Okay, bone marrow, including bone marrow. Okay. So first type is hyperacute. Second is acute. Then third is chronic. So let's begin. Three questions. When does it happen? What exactly happened? And what can be done about it? Let's start with hyperacute. This occurs within 24 hours up to the third day. So 24 hours up to the third day. So first 1, 2, 3 days after the surgery. The good thing about hyperacute is it's extremely rare. Because did we just do this transplant, without doing any testing? No. This graft, this organ, this tissue is very precious, right? It's not every day that you see a car accident there and then you harvest those organs. It doesn't work like that. Okay. So we did our due diligence, and make sure it's going to be a good enough match, right? That we did the blood typing, we tested the graph for infectious disease, and then we did the HLA matching. Okay, so we did our job, and then we did the immunosuppression as well, right? So therefore, it should not happen that there's be a rejection. However, because this is rare, and when it does happen, what actually happened is this is a freak accident. This is a freak event. What happened is there was an unexpected reaction when the blood flow when my blood went through let's say we put the Stephanie's kidneys into my body, right? As soon as my blood started flowing into the arteries and capillaries in Stephanie's kidney, there was a reaction. It it activated the clotting cascade. As a result, the graft developed so many blood clots in it. So every capillary, artery, and vein inside Stephanie's kidney that she put into mine got obstructed by blood clots. Now, since it's full of clots, what will happen to it now? Will there be any oxygen in it? No, because it's all filled with clots. So instead of turning pink, red, and alive, so what will happen to it? It'll turn gray and then black. Okay. So what can be done in that case? Can we still save it? It's already black. It's dead. So what can we do? Take it out. Put it on the grill. No, put it in marinade soy sauce first and then put it on the grill. Okay, that's all we can do. Any question on hyperacute? Good thing again, this is extremely rare. Okay, I attended a symposium in Gainesville, Florida, about how many cases they were talking about transplant rejection. And the surgeon there, although he was young, he was in his 40s, he said he's never seen it. He performed thousands of transplants. He said he's never seen it happen. Okay, hyperacute is extremely rare. Let's go to the next. Acute. Now, within 3 to 14 days, or actually, the thing about acute rejection is, yes, it will occur between the 3rd and 14th day. However, it will not be a one-time event, meaning it can occur sporadically over the next several years. But each episode is distinct. Okay? Do you understand do you understand what I'm saying? Meaning it's not limited to one event. So let's say we have an acute rejection on the 14th day, and then we manage it, and then we saved it, right? And then everything went back to normal. Next year, I could have another one. Does that make sense? Okay, so it's not a one-time event. Each one, though, is an acute rejection episode. Okay, so therefore, how do we describe this? It'll be between third to 14th day. However, sporadically throughout the life of the graft, meaning it won't be a one-time event. it will occur again and again and again and again. But each episode is an acute rejection episode. So, what exactly happens with each episode? Remember, I said earlier, what doesn't kill you makes you stronger, right? So, what did we do to the host again? So, what did you do to me to make sure her graft, her kidney doesn't get destroyed? What did you do to me? You gave me immunosuppressants. For how long? For every day, for the rest of my life. Okay, I keep taking it every single day. However, will there be instances that I will get sick? Yes, because I'm taking immunosuppressants. Of course, I'm prone to infections, right? So let's say I got sick, and then now what did you have to do with my medications? Okay, so maybe it wasn't the doctor, maybe it was me. Okay, I couldn't take the pill, right? So, or let's say some other event happened wherein my immune system got away somehow. Okay, got stronger somehow, and then managed to throw a punch. Yeah, punch Stephanie. I want to. I got yes, son of it. Okay, we got Stephanie's kidney even just once, or one or two hits. All right, so that's enough to cause an acute rejection. So of course, the patient, me a patient, I will have manifestations of what? Acute or chronic kidney disease. Acute. I will have acute kidney injury manifestations. Okay, just like the pre, intra, and post-renal acute kidney injuries. Okay, so that will be my manifestations. And what can be done about it? Since it was a acute episode, can I do something? Or is Stephanie's kidney gone? Can we still save it? Yes, we can still, because what happened again? What did my immune system do? It got stronger, right? Managed to land a punch or two. So what will we do? Increase the immunosuppression. So the doctor recognizes, okay, yeah, you're having acute rejection symptoms. So what we'll do is we'll give you extra doses. We'll increase the dose, and then they'll also add medications. Now, during acute rejection episodes, the patient usually is given steroids, IV steroids. Okay, for a short period of time, maybe a few weeks, okay, just to make sure her immune system is really suppressed. Okay, so it stops destroying the kidney, because I need a kidney. Okay, I don't want my immune system destroying. So for a few weeks, I'll be taking steroids as well as higher doses of my usual medications. Okay, does that make sense? All right. And then once the acute rejection is over, then I'll be back to my previous dosage. Okay, and then everything's good. Any question on acute? Let's go to the last, chronic rejection. In chronic rejection, since when it says chronic, let's say just like in chronic kidney disease, did we notice the changes or the manifestations overnight or like this? No, it occurred slowly over months, over years. Okay, so this is what happened. Because I was given steroids, immunosuppressants rather. So there's therefore um, constant suppression of my immune response, correct? So that will still cause a little bit of, because again, there's no perfect match. So basically, Stephanie's kidney is my body. Does it cause inflammation? Because it's a foreign object, basically. So will it cause some inflammation inside my body? Yes. So therefore, the nature of chronic rejection is overall inflammatory process occurring over time. So slowly, every few months, every few years, there's inflammation, and then little by little, that graft, that Stephanie's kidney inside my body, died a little bit at a time. Okay, it slowly failed over several months, over several years. So when if once the doctor sees it, I'm already on, let's say, stage 2, stage 3, and then eventually stage 4, stage 5, kidney failure, kidney disease. What can be done about this? Same as acute rejection, once we find out and decide that, oh, we conclude, oh, this is chronic kidney rejection. What can we do at that point? We can delay it. Okay, we can delay. That's all we can do because the organ was already damaged as well. Okay, but it's still functional, so we can just conservatively treat it by we can increase the immunosuppression. Plus, of course, I can't take nephrotoxic agents anymore, meaning, I'll try my best not to take NSAIDs, antibiotics, okay, or other medications that will harm my kidney, because that's all we can do. Because there's already slowly, there's already destruction of the graft of Stephanie's kidney, slowly over several months, several years. However, it's inevitable. It's eventually gonna fail again. So it's just like what happened to me before I got the transplant. So can I go back on dialysis now? Yeah, I will have to. Once I reach stage 5, then I'm back on dialysis. I'm back on the transplant list again. And then I'll wait again until the next donor comes. All right. So can I have multiple transplants in my lifetime? Yes, if I'm lucky, if there's a matching donor, why not? Okay, it wasn't my fault, right? The organ failed. Okay? I had chronic rejection, or let's say it was hyperacute rejection. There's nothing we can do about that, right? So finally, these are the medications we're using. Table 48-4. Again, this will apply to whichever transplant we're doing, whether it's a bone marrow, an eye, a heart, a lung, a liver, a kidney, same medications. So we've got tacrolimus and cyclosporin. Both of these are calcineurin inhibitors. And what is calcineurin? Because calcineurin will activate helper T cells, helper T lymphocytes, and these helper T lymphocytes are the ones that will kill and destroy foreign cells, including cancer. So therefore, what is the consequence of taking these medications? Since T cells are responsible for recognizing and attacking cancer cells, and you're suppressing them, what will be a side effect? Can I develop cancer? It's possible. Okay, so it's possible that taking these drugs may cause cancer down the road. Because why do they cause cancer? They're suppressing my T lymphocytes. T lymphocytes are responsible for identifying and killing cancer cells. So since these two are the same, they're calcineurin inhibitors, then they're both toxic to the kidneys, causes hyperkalemia, and etc. Sirolimus, an mTOR inhibitor, does it differently, but still inhibits the B and T lymphocytes. B lymphocytes are like your memory lymphocytes. These guys are responsible for antibody formation. The cheapest among here is mycophenolate, an anti-proliferative. You'll see this later in 2 weeks. We'll talk about cancer. Mycophenolate is one of the cancer drugs. However, because they are not very cell specific, meaning they inhibit B and T lymphocytes. However, they will also inhibit other rapidly dividing cells. So it will also affect your red blood cells, white blood cells, and platelets as well. And the GI tract is also rapidly dividing, so it can cause GI upset as well, diarrhea. So, any questions? So whenever these patients are on these medications, what is your goal? For taking immunosuppressants. what should you initiate? What kind of isolation? Contact or protective isolation? Protective isolation. So they're at risk for infection. So instead of them being infectious to us, we are infectious to these patients. So we put them on protective or reverse isolation. All right, that's it. Any questions?